Today's cataract surgery is like the game of past. We have just one chance to hit it right. Traveling back in time, the complex situations that we have created in the past are now coming to us, presenting with cataract. These patients are often very demanding and want a perfect refractive outcome, increasing the challenges for the doctor. Like this patient, post-keratoplasty, topography showed a 14 diopter of astigmatism. We planned a customized 13 diopter of toric intraocular lens for this patient, which was specially designed for him. Post-surgery, outcomes were rewarding, both in terms of subjective and objective measurements, as seen on ray tracing aberrometry. In patients post-keratorefractive procedure, we cannot generalize the cataract surgery because unlike normal unoperated corneas where the ratio between the anterior and posterior corneal plane is maintained, in such complex corneas, the ratio is disturbed, leading to technical challenges in calculating the IOL power. The most important challenge is how do we calculate the IOL power? Like in this case, 55-year-old female presented with cataract. Her topography shows a well-centered ablation profile. To calculate the IOL power for such patients, we have various options. Option 1. We can calculate IOL power using AIOC online calculator. 65% mean keratometry with 0 to 4 mm mean zonal equivalent keratometry is used. Along with keratometry value obtained from the anterior float, and actual length from the optical biometer is used. Studies have shown AIOC's minimum value is considered to be the most accurate for IOL power calculation. Formula used in AIOC's calculator takes into account the alteration caused to corneal surface post-refractive surgery. Option 2 includes keratometry obtained from total corneal refractive power, which takes into account both the anterior and posterior surface and actual length from optical biometer. IOL power is calculated using Holiday formula. Similar guidelines are followed for patients post-hyperopic and radial keratotomy. In radial keratotomy patients, AIOC's average or maximum is considered as these patients have a hyperopic shift post-surgery. Then the question comes, which IOL is to be used? The Holiday EKR report uses Snell's law to calculate the keratometric power. It gives keratometric values from 1 to 7 mm zone independently, along with the histograph, which gives a graphical representation of the distribution of keratometric values. Like in this patient, considering small astigmatism as well as a broad-based distribution of the equivalent K readings, a toric IOL implantation was deferred. Whereas, in this case, considering that the magnitude and axis is maintained along all the zones and the histogram showed a tall peak with narrow base and eye trace ruled out other source of aberrations, we planned for a toric IOL. The next case is of a patient with well-centered ablation profile. Her keratometry is constant in all the zones and histograph shows a tall peak with narrow base. Zone K reveals less higher order aberrations and eye trace confirms the source of aberrations, hence multifocal IOL was planned. For toric intraocular lens, along with keratometry, pupillometry is also important. In this case, the mesopic pupil size is 3 mm and scotopic pupil is 4.9 mm. Hence, we look for the keratometric distribution till the 4.9 mm zone on an EKR map. For toric calculation, we use the spherical equivalent from AIOC's calculation and axis by online calculator using the keratometric value from the scotopic pupil size zone. The question is, can we use toric in such situations? In keratoconus, it will depend on the location of the cone, whether it is central or bisecting the pupil or a peripheral cone. Like in this patient with central cone and scotopic pupil of 5 mm, EKR report shows wide keratometric distribution and a varied axis. Hence, we planned for a monofocal IOL in this patient. Whereas in this case, with cone bisecting the pupillary margin, considering the magnitude of keratometry and the axis to be constant, we can go ahead with the toric IOL. This is a case of a 37-year-old female who presented with post-LASIK ectasia. Her EKR shows a broad-based histograph with multiple peaks suggesting irregular keratometric distribution. Hence, we planned for a monofocal IOL with incision on the steep axis. Opposite clear corneal incision or limbal relaxing incisions are deferred in such cases, considering that they are biomechanically weak corneas. There are various commercially available IOLs. For patients post-hyperopy classic or with negative asphericity, a positive aspheric IOL is suitable, while for patients post-myopic ablation, a negative aspheric is much better. Cases with weak zonules, decenter ablation or large angle kappa, a zero asphericity IOL is preferred. This is a very interesting case of a 52-year-old female with decentered ablation. Ray tracing aberrometry reveals higher-order aberrations contributed not only by the lens but also by the cornea. As we know, the total optical aberrations is contributed by cornea as well as the internal optics. If we only treat the lens, patient would still not experience optically clear vision. In such situations, we plan to regularize the corneal surface before cataract surgery. A topo-guided, customized ablation treatment was planned. Post-treatment, the topography showed a regularized surface, and hence we proceeded with cataract surgery. This method not only helps us in selecting a more customized IOL, but also for a more predictive refractive outcome. To optimize our results further, we can use intraoperative real-time OCT-guided measurement of the effective lens position, or a computer-simulated modeling using intraoperative SD-OCT. The role of corneal biomechanics should also be kept in mind, as these are biomechanically weak corneas. To summarize, customization of IOL power calculation and surgical technique goes a long way in ensuring perfect refractive outcome post-cataract surgery in patients with history of keratorefractive procedure.